Frank, for this excellent presentation. It's nice to see your data. And as I was provocative with the first speaker, I will try to be provocative with you as well. If you allow me, if I look at your patients over time, and by the way, I like very much the fact that you looked over time to see what's happening. What's so surprising to me is that suPAR levels do not decline. And if I compare it with patients with malaria, after 7 days, most of these patients are better at that moment. They have very much lower suPAR levels. In fact, they're comparable to the healthy controls. So if I look at your data, there's something interesting happening. For instance, you compare survivors as non-survivors, right? On day 7, when I look at your groups of patients, I see that approximately 2/3 of the survivors has gone out of the analysis, which is logical because sometimes as an intensivist you're treating patients successfully.
That was what I wanted to note. If you stay for 7 days on the ICU, you must be still ill, and so it makes sense to have high suPAR levels.
So this brings me to another question, and hopefully you can provide me with those data, or otherwise maybe you can look that up. Maybe the levels of these patients are still high because they are still severely ill. They might still survive, but they are severely ill. So could you make any correlation or association with SOFA score or other organ failures, for instance?
Yeah, actually suPAR is correlated to those scores. It's also correlated, for instance, to vasopressor demand or to ventilator settings like PEEP or fractionated oxygen. So it makes sense that the patients are still ill. I'm not so sure if we have looked at day 7 because the groups become much smaller, so it's difficult to really work out the correlation analysis then. But I completely agree with you. If somebody stays at the ICU, he or she is most likely still severely ill. And so that explains possibly why suPAR is so high. Unfortunately, we have not taken samples after discharge from the ICU, which would have been extremely nice. And I can only suggest that to anybody who is conducting the next story, the next project, the next study, to really look and maybe take samples even on follow-up visits. I mean, we had expected really like the SOFA score, who the decline in SOFA score would predict survival, or so. We tested if a decline in suPAR would tell us something about survival or death, and it was not so, because it was just not really a decline in the patients. The diagnosis of sepsis was not made at admission, but judged later. So kind of the patient was classified later in a blinded, or in a fashion blinded for suPAR levels by the physicians if the patient had sepsis or not. Because I agree with you, it's really difficult to say.
So as by definition, there was infection, period.
Yeah. We don't know, actually. It could be that there's a constant production of suPAR, or that it's just a problem of the clearance, that it cannot go down due to renal failure or hepatic failure. And we cannot really discriminate between those two possibilities. It's not perfect. It's just better or similar as good as other single laboratory markers. So I guess if we compare to the to clinical scores, I personally don't believe that suPAR by itself is better than the Apache score or the SOFA score. But if you compare to single biomarkers, a biomarker that tells you about liver function, which is also significant on Cox regression analysis, the suPAR reaches a higher AUC under the ROC curve. If you compare to other biomarkers, it is superior or similar, but it's not superior to clinical scores.
Thank you very much for this excellent presentation.